It is now my pleasure to begin the plenary sessions by inviting to the podium Dr. Ron Hoffman from Mount Sinai Hospital in New York to speak to you on drivers of progression of MPNs.
It's a real pleasure to come here and give this talk. Actually, this is the talk that makes me most nervous each year because it's very difficult, for me at least, to clarify these issues. So excuse me if I'm a little bit geeky. I apologize for that. So all the patients that we see are always concerned about progression of their disease. We all know what myeloproliferative disorders are, and this is what this talk is about. Here are my conflicts of interest. These are basically support that we get from pharmaceutical companies, which is really important because we don't make drugs. Pharmaceutical industry makes drugs, and we're involved in essentially determining whether these drugs are going to be effective in patients with myeloproliferative disorders. So I'd like to start this off essentially trying to allow you to understand what is the differences between initiation, the start of a myeloproliferative disorder, and also progression of this disease. And all of you who unfortunately have myeloproliferative neoplasms have had the initiation event, but you're most concerned about the disease getting worse or progressing. So this is a schematic diagram. It's a little bit tough to do this, so I think I'm going to do it here. It's not going to work, but we're most interested in the initiation of this disease. And how did this group of diseases really occur? It was really described in 1960s by one of the most famous hematologists of all time, William Damashek. And what this, based upon clinical criteria, what he determined was that these disorders, polycythemia vera, essential thrombocythemia, and primary myelofibrosis, as well as chronic myeloid leukemia, shared many clinical features. And one of them, each of them could evolve from one to the other, like a patient, as you can see here, with PV, with ET can go on to PV and then go on to symptomatic myelofibrosis and then unfortunately to a secondary form of acute leukemia. So the disorders that we're interested in are essentially ET, polycythemia vera, and primary myelofibrosis. And these are all stem cell disorders. And what we've learned over the last decade or so is that many of these patients essentially have a very early form of a hematologic disorder, even when they have normal blood counts, and that's called clonal hematopoiesis of indeterminate potential, when they either have just a JAK2 mutation or a calreticulin mutation. What's been recently shown that these disorders that these mutations can actually be acquired in utero during fetal development, and that it takes many decades for the clinical consequences of these mutations to really occur. And there are three driver mutations that you all know about, basically JAK2 V617F, or an exon 12 mutation of JAK2, a mutation in MPL, and also a mutation in calreticulin. And each of these mutations results in increased intracellular signaling through a pathway that's called the JAK-STAT pathway. And all that you really have to understand is that these mutations initially lead to accelerated proliferation of primitive hematopoietic stem cells. And hematopoietic stem cells are the mother cells that give rise to all the formed elements of the blood. So that's the initiation event. And what's been shown in the UK is that not all the patients start off with a JAK2 mutation. Their disease can also be preceded by other myeloid mutations and then acquire the JAK2 V617F. And that can sometimes lead to a different phenotype or different type of disease. So that's the initiation event. It's JAK-STAT signaling, increased JAK-STAT signaling due to these mutations. Some of the patients even lack known mutations, but they still have JAK-STAT signaling. Unfortunately, after a number of years or decades, these patients then go on to progress. So let's take this patient, let's say a young female who had essential thrombocythemia was totally asymptomatic, let's say at age 25. The thrombocytosis was picked up just by chance. 10 years later, that patient is shown to have erythrocytosis. So her disease has progressed to polycythemia vera. That is, she now not only has thrombocytosis, she also has erythrocytosis. And during this proliferative phase of the disease, the major cause of death and discomfort from patients is really clotting and thrombotic events and also hemorrhage. Unfortunately, perhaps after a decade longer, this patient then goes on to develop symptomatic myelofibrosis. And there's a switch that turns off because the proliferative phase of this disease, which is essential thrombocythemia, polycythemia vera, or the very early forms of myelofibrosis, are characterized by excessive blood cell production. Here, when you go into the myelofibrotic stage, the stem cells are ineffective in producing increased numbers of blood cells. And then a minority of patients then go on to develop MPN blast phase, which is a very difficult form of secondary acute leukemia to treat. The first thing I'd like to mention to you is not everyone with an MPN has progressive disease. And even if you evolve, you can be arrested at that particular stage. So it's really the minority of patients with polycythemia vera or essential thrombocythemia or an early form of myelofibrosis that actually progress to overt myelofibrosis and eventually to MPN blast phase. So the major cause in the proliferative phases, let's say PV, ET, and early forms of myelofibrosis is really thrombosis and hemorrhage. Now, we do know that essentially the impact of these driver mutations in many ways determines the outcome of patients, at least with primary myelofibrosis. And you can see that those patients that have calreticulin mutated disease, which occurs in ET and also myelofibrosis, have a better survival of those than those patients who have JAK2 mutations or MPL mutations. And unfortunately, those patients that have histologically documented myeloproliferative disorders that lack a mutation, they have the overall worst survival. Now, we've learned that there are additional mutations, myeloid mutations, that occur in patients with myelofibrosis, such as mutations in P53, in genes that affect methylation and splicing of RNA. And those mutations are secondary mutations that confer a poor prognosis. So based upon the clinical characteristics and also these secondary mutations, we can essentially determine the prognosis of patients that have myelofibrosis. And you can see that as you have more and more of these features, your prognosis worsens. So what is the standard of care for patients with symptomatic and more overt forms of myelofibrosis right now? And I'm using this as an example of how we can intervene in progression. Well, it's actually really a wonder drug. The JAK1, JAK2 inhibitors, the first one of which is ruxolitinib. And now there's also fedratinib, pacritinib, and momelotinib that are approved for therapy of symptomatic patients with myelofibrosis. And here you can see this is a randomized study comparing ruxolitinib or Jakafi to placebo. And you can see that there's a dramatic reduction in total symptom score and also a reduction in spleen volume. And this group of drugs has really revolutionized the care of patients with myelofibrosis, really improving their quality of life. The problem with JAK2 inhibitors is that when the patient's no longer able to survive, as you can see here, the median overall survival is essentially 14 months. And after about 5 years, approximately 83% of patients will no longer respond to one of these JAK2 inhibitors. So this present standard of care, if your disease no longer responds to Jakafi, what people do, what physicians do, they switch to another JAK2 inhibitor depending upon the clinical context, that is the blood counts of the patients, whether the patient is anemic or thrombocytopenic. So one group of thought is that we will be able to circumvent this progression by developing a more effective JAK2 inhibitor that will not only reduce spleen and symptoms, but will essentially eliminate the stem cells that give rise to the myeloproliferative neoplasm and are responsible for progression. So Ross Levine and Andy Dunbar, working in a company called Ajax, and Ross is across the street at Memorial Sloan Kettering, they've developed a new type of JAK2 inhibitor called a type 2 JAK inhibitor. And all you have to realize is that this essentially irreversibly binds to the JAK-STAT pathway, to JAK2, and leads to more complete inhibition of JAK-STAT signaling. And what they've shown here at ASH last year is that these type 2 JAK2 inhibitors, here's their Ajax compound, and this is going to go into the clinic probably in the fourth quarter of this year, essentially reduces the number of hematopoietic cells to a greater degree than ruxolitinib and also decreases the splenic weight. So it appears to be more effective. But the question is, does it actually target the stem cell? And the other question is a specific JAK2 V617F inhibitor on the horizon? From my understanding, we'll learn about that in December at the American Society of Hematology. Why is it so difficult to cure patients with myeloproliferative disorders and prevent disease progression? The reason for that is shown in this slide. And what we did here is essentially took stem cells from patients with myelofibrosis and transplanted them into immune-deficient mice. And what you can see here, these are the different lineages of the cell, the different hematopoietic cell lineages. And what it showed on the top panel and also on the bottom panel is that the markers of the disease, the mutations and the cytogenetic abnormalities, once these cells were transplanted into mice, essentially were present in all hematopoietic lineages, indicating that the common stem cell, which gives rise to these different hematopoietic lineages, essentially is responsible for this disease. And stem cells are very hardy cells. They can survive total body irradiation. So it's very difficult to eliminate these stem cells. Now, this is a very complex slide. And what essentially it does is at the single cell level, it looks at the presence of the various mutations that are present in this patient. So here you see your friend JAK2, or your enemy JAK2, I should say, NRAS, TET2, and ASXL1. And these are various clones that have various representation of these various mutations. And that indicates that there's not a single clone, but there are multiple clones. And one of the clones is really a bit scary because here you can see that, first of all, the good part is that there are some clones that don't lack any mutations. So that means that there are normal stem cells there. And that means that if we eliminate the malignant cells, these normal stem cells can repopulate. But this clone is a particular scariness because 40% of patients who have JAK2 V617F myeloproliferative neoplasms, when they go on to develop MPN blast phase or acute leukemia, lose the JAK2 mutation. So this clone, which we can see, has the other mutations but lacks the JAK2 mutation. And this is a potential clone that could give rise to this leukemic event. So the body, unfortunately, has set up a whole bunch of pathways beyond these mutations that essentially protects these malignant stem cells. And the most important part of it is the interaction between these stem cells and the environment in which they sit, whether that's in the marrow or whether that's in the spleen or in the liver. So these stem cell, progenitor cell interactions essentially protect the hematopoietic stem cell that's involved by the myeloproliferative neoplasm. In addition to the JAK-STAT pathway, which is outlined here, and you really don't have to go through it, there are a number of other regulatory pathways that are upregulated, such as NF-kappa B, which promotes the inflammatory milieu. There's downregulation of the tumor suppressor gene P53, and there's also upregulation of another transcription factor that's involved with hypoxia, which is called HIF-1 alpha. So really, we have a lot of barriers. And the question really is, if we attack these other barriers beyond the JAK-STAT pathway, will we be able to eliminate these stem cells and prevent progression? Because remember, these patients have progressed on a JAK2 inhibitor. So it would be likely that these other events, at least from my point of view, are responsible for progression. And that's the underlying hypothesis that we're dealing with, in contrast to what my colleagues' equally viable hypothesis that Ross Levine and his colleagues, and also the folks at Insight, are going after. Well, one of the sobering things that we did was we looked at JAK2 inhibitors, and we treated MPN stem cells with these JAK2 inhibitors, and essentially we transplanted them into NSG mice. And this is the percent of human cells, and the black bar is essentially untreated, and these are cells that are treated with a JAK2 inhibitor. And you can see that essentially the amount of stem cells that are present is not depleted by an inhibitor of JAK-STAT signaling. And that likely indicates some of the limitations, at least with the first generation JAK2 inhibitors, and why we get progression, that there are additional events that are responsible for progression. We, at present, have a stem cell depleting or eradication method, and that's called allogeneic stem cell transplantation, where essentially we replace the malignant stem cells with normal stem cells. And this is a diagram that's essentially been taken from a paper from Bacigalupo's group in Genoa a number of years ago. And here what it shows is that here are the outcomes of transplanting myelofibrosis patients in the years 2000 to 2010. And here you can see 2011 to 2014. So transplantation has improved. And you can see, at least in this clinic in Genoa, that 72% of these patients who have identical siblings are essentially cured of their disease when you eliminate the stem cells. The exciting thing here is that we have additional donors, because not everybody has a stem cell donor. And we can do things like haploidentical transplant. Let's say one of your parents, if they're alive, or one of your kids can serve as a donor. So that expands the possibility. So the reality is that essentially myelofibrosis and a lot of these diseases occur in people that are over 60 years of age, and I'm not going to call that elderly because I fall into that category. So what this shows is this is just a paper that was published from Europe showing that they took patients, again, selected patients who were fit, who were not obese, who didn't have diabetes, who didn't have complications, and they transplanted them. And this is really exciting because it shows that you can transplant patients over 65 years of age and have really good outcomes. So what this proves is that a stem cell therapy will essentially cure patients with myelofibrosis. And our goal, all of the physicians in this room, our cumulative goal is essentially to identify drugs that will deplete these hematopoietic stem cells that are involved by this malignant process, to a sufficient degree to mimic what occurs with an allogeneic stem cell transplantation. So we never have to put patients through that terrible year that follows allogeneic stem cell transplantation. But when you get out of that tunnel, essentially, of allogeneic stem cell transplantation, if you're fortunate enough to make it through it, you're essentially cured of your disease. So our underlying hypothesis, and I think the mission of this field, is really to prevent progression. We must deplete these stem cells, disarm this tumor microenvironment, and this is going to require the use of strategies using approaches beyond JAK-STAT signaling. And JAK2 inhibitors are not the only target for effective drug development. So this is not to minimize the contributions of the JAK-STAT inhibitors, the JAK2 inhibitors. They have revolutionized care, but we have to go to the next generation. We have to take the next step. We have to cure this disease in the next decade. So I have a lot of hope and optimism because we have a growing number of candidate approaches that will deplete MF stem cells and prolong patient survival in patients that are no longer responsive to JAK2 inhibitors. One of those drugs is potentially interferon, where the pioneering work was done here at Cornell, and some of it was done at Sinai. So the question that I raise is, will regimens that do not include JAK2 inhibitors contribute to the depletion of hematopoietic stem cells and be effective in treating patients in which JAK2 inhibitors are no longer effective? So can we disarm the hematopoietic microenvironment that supports these stem cells? Can we attack beyond JAK-STAT pathway? Can we attack NF-kappa B? Can we attack HIF-1 alpha? Or can we upregulate P53 to cause depletion of these stem cells? And I'm very optimistic about this. I think there are a variety of approaches that, if I have time enough, I can show to you. So one study that really shocked me is a sort of a funky type drug that's been approved for patients with myelodysplastic syndrome, but we were working with it years ago. It's a drug that essentially attacks the enzyme called telomerase that leads to lengthening of the length of chromosomes. So, and that drug is called Imetelstat. And what we showed a number of years ago, and I'm just going to summarize this. You can look to the right. This is the total number of hematopoietic stem cells in these transplanted mice. And this is the number of CD34 cells. What we showed in a variety of patients in those white bars is that Imetelstat can essentially deplete, not eliminate, but deplete hematopoietic stem cells from patients with myelofibrosis. And this translated into this protocol, which was published by my colleague John Mascarenhas and his colleagues at Sinai and other institutions, which showed that Imetelstat was indeed an effective treatment. And the most exciting thing is shown in the right here. You can see that it wasn't a randomized trial. They had some patients that got low doses of the drug, and then other individuals that had higher doses of the drug. And what it shows here is in the blue, those patients who had higher doses of the drug lived much longer, essentially an average of about 29.9 months, in comparison to those patients that got lower doses of the drug. And this drug, and that's the first inkling beyond transplant, that we can essentially prolong the life of patients with myelofibrosis. And this appropriately is now being evaluated in a phase 3 trial. We've been really interested in targeting the P53 pathway, which is a master regulator of tumor suppressor gene protecting us from cancers. And what we showed initially here is this is the amount of P53 that's present in the stem cells on the right with myelofibrosis stem cells versus normal stem cells. And you can see that it's decreased. So we have decreased reduction of this tumor suppressor gene. And we showed initially that interferon essentially increases p53. So perhaps it does indeed target stem cells. Now, p53 is regulated by a number of molecules, one of which is called MDM2, and it leads to the degradation of p53. So what we showed here in this graph, here you can see normal individuals, polycythemia vera patients, and also myelofibrosis. You can see that there's a stepwise increase in the amount of MDM2. And that means that there's degradation of p53, that tumor suppressor gene, that essentially protects us. It's a guardian. So investigators at Roche Pharmaceuticals developed a class of drugs called Nutlins, named after Nutley, New Jersey, which is the next town from where I grew up, which was Passaic, New Jersey. So this group of drugs essentially attacked or antagonized the effects of MDM2, leading to upregulation of p53. And we used this strategy essentially to incubate cells with these various drugs and then transplant them into these immune deficient mice, essentially to determine if we can deplete stem cells. And to go to the quick, really the short here, you can see one of these MDM2 inhibitors, which is called HDM201. You can see that in each of the lineages and also in CD34 cells, indeed, when you treat these stem cells from patients with myelofibrosis, it leads to reduced numbers of hematopoietic stem cells. And this has led to a number of clinical trials, some of which were initiated at our institution. But here's another MDM2 inhibitor called navtemadlin, and this was presented last year in Europe at the European Hematology Association. So this drug is interesting. It's got some toxicity, but it does have clinical benefit to patients with myelofibrosis. And here you can see that it leads to reduction. These are all patients that are refractory to JAK2 inhibitors, and you can see that it reduces spleen volume, and it also reduces total symptom score. So it does a lot of the things in these patients that are refractory to JAK2 inhibitors that we were looking for. But the most important thing is it prolongs survival in this phase 2 trial in comparison to historical control. So this drug is also being evaluated in a phase 3 trial, and hopefully these phase 3 trials will all work out. Now we have other candidate partners for HDM2 antagonists that further upregulate myelofibrosis, p53. And I think the most exciting ones are basically selinexor, which is a drug that keeps p53 in the nucleus, and also these bromodomain inhibitors, in addition to an inhibitor of anti-apoptotic proteins. One of the things that's revolutionized oncology is the use of immunotherapy. And we have unfortunately failed essentially to use immunotherapy to date to treat patients with myelofibrosis or with polycythemia or interferon, or with essential thrombocythemia. Transplant is the penultimate form of immunotherapy. So, and when we do donor lymphocyte infusions after a patient has, let's say, relapse from a transplant, that's immunotherapy. So that suggests that immunotherapy is an important approach that could be used in the future to treat patients with myelofibrosis. So we're trying to do this, and one of the barriers, unfortunately, to this is that more overt forms of myelofibrosis are characterized by exhaustion of T cells. So what Dr. Hasselback and his group in Denmark have completed, and what we're just starting with another vaccine, we're trying to develop a vaccine program to the mutated form of calreticulin. And because we're using that as an antigen to harness the body's immunity. And the first 3 patients, at least at our institution, are on this program. And it involves patients who have calreticulin disease and also myelofibrosis who have the calreticulin mutation. And I think that that approach has some real promise. Last year at ASH, there was a paper that was published about a monoclonal antibody that was specific to calreticulin. That's really pretty fantastic, because if that monoclonal antibody can deplete myelofibrosis stem cells or essential thrombocythemia stem cells, that monoclonal antibody will essentially have the potential to deplete those stem cells to the degree that would be leading to cure of these patients. And this trial, the phase 1 trial, is ongoing, and I think the first patient was treated in Australia, and the second and third patients are going to be treated at our institution. We've already selected them. Now, there's one other class of drugs that I'd like to talk to you about, and those are epigenetic therapies. And epigenetic changes, you probably have never realized, are modifications to DNA that regulate whether genes are turned on or off. So they don't involve mutations, but they involve changes in conformation of the DNA that essentially affect gene expression. And this is an important target of therapy, and in myelodysplastic syndromes, it essentially has led to the approval of the standard of care. So there's strong preclinical rationale for using epigenetic therapies. Our lab has shown that epigenetic therapies can increase a receptor present on myelofibrosis stem cells. It can correct abnormal trafficking of these stem cells, and then it can actually eliminate MF stem cells. And Rajit Rampal across the street has shown that there's synergistic anti-clinical activity between hypomethylating agents and JAK2 inhibitors. And also, one of the mutations, ASXL1, that leads to hypermethylation, which essentially provides, and that's a bad prognostic parameter, that essentially provides the rationale for these hypomethylating agents. So very quickly, here's a trial from MD Anderson. It only included 25 patients, but you can see that there were responses using essentially this hypomethylating agent. And the median overall survival of these patients in MPN blast phase was 9.5 months, which is increased over the historical controls. So we presently are going to present at ASH a paper on an oral combination of a form of this drug called oral decitabine, in which we've been able to be treating patients with epigenetic therapies who have failed or who no longer respond to JAK2 inhibitors. And fortunately, we've been able to prolong their survival, and hopefully this will lead to a phase 2 trial and eventually a phase 3 trial. So my bottom line is Nobel Prize winner Bob Dylan, who would have thought that? The times are really changing, and I think it's a time for optimism in this field. And we've really had a tough time of finding drugs, but we finally had the attention of pharma. And this is only going to get better if we interact, the academic community, the patient community, and the pharmaceutical community essentially have a marriage to essentially cure these myeloproliferative neoplasms by depleting stem cells. And here are the people that work with me, especially the investigators in our consortium, the pharmaceutical industry, the research foundation, and most of all, you, because we couldn't do these studies without yourselves, and we really count on your participation in clinical trials. So I hope this talk was meaningful for you. It was meaningful for me to put it together. And it explains, I think, why we're having such a problem, but I think we can surmount this in the not too distant future. Thank you for your attention.
Thank you, Dr. Hoffman, for this very comprehensive overview of the science of disease progression across the MPN spectrum and how we can target disease progression clinically. A lot of great ideas as far as targets and drugs, and I know we're going to hear more about that later today.